It is a pleasure to be here today. This is my first visit to Cleveland, and the narcissistic part of me says, you know, because I'm here, President Obama came as well, because he wouldn't come to Maryland where I live because we already have the vote there. So there's been a lot of discussion about stories and narratives, and so I'm going to tell you a little bit of a story. Paul didn't want me to spend too much time on background, but I have to make sure that you all are somewhat grounded, so a little piece of history. How many here have been in the military themselves? Okay, just a couple of you. Well, one of the things we do in the military at times is we forget our lessons from the past. So I want to remind you all of some of the lessons from the past. And this is a brief version, but it's very important that we look at our history. And some of you know this very well already. And I think it's going to play into some of the themes of this conference where there's a blurry distinction between what is neurological, what is psychogenic, what is psychological, where is a secondary gain involved, issues about informed consent and confidentiality. It's been very interesting for me putting together this talk. I was this week at Fort Campbell and last week at Fort Bliss, recently at Camp Lejeune, with the lens of ethical issues in mind, and so I'm going to be using those and my long time in the Army to frame some of these. But in brief, the history lesson. One of the things that we tend to do at the beginning of the war is pull people out too early. If they're pulled out of the war for either shell shock or battle fatigue, they never go back in again, and they maintain the shame and stigma of being a nutcase, whatever term you want to call it, for the rest of their lives. If you keep them up close on the front line, they do better. And that's been our doctrine. Now, there's some discussion of should we be changing that in this current war, and I'll circle back to that. But we do treatment far forward on the front line, principles of proximity, immediacy, expectancy, and simplicity. And most people do better after they get over their grief, their exhaustion, their dehydration, and they can stay in and join the fight. What we don't actually know is the long-term outcome of how many of those people do well, but they certainly can function in combat again. Vietnam was the war that gave birth to the name post-traumatic stress disorder, although of course we didn't recognize it as such until 1980. We had drug and alcohol use. Desert Storm, remember that war? Not that long ago, 1990. We had a lot of medically unexplained physical symptoms known as Persian Gulf illnesses. And then we have done pretty well with far forward mental health treatment using the principles of PI in all the operations other than war, such as Haiti, Bosnia, Kosovo, Somalia, and we have kept people in the fight. My world changed on 9/11. I'm sure everybody's world did. I was stationed at the Pentagon then. I was very involved in the treatment. The Pentagon got lost in the New York story, got forgotten, and that's as it should be. Many, many more died in New York. At the same time, I think we did a really good job with some of the principles of far forward treatment. Another talk, which I won't go into too much here, but is the importance of memorials and recognition. If you haven't been to the memorial at the Pentagon, I would recommend that you go. 184 benches for each of the people that died there. In New York, 9/11 is still there. In the military, 9/11 is only the beginning of the 11 years of war we've had since then. To remind you, there's been numerous stressors with multiple and extended deployments. Other wars, by and large, World War I, World War II, you went over, you stayed for the duration, and you came back. Vietnam, Korea, most people went for 1 year, came back. This war, you've got people going back and forth, and that brings up a perhaps new ethical issue, which is if you've already developed post-traumatic stress disorder, should you be staying in the States as a casualty of war, or should you be deploying back in with your unit? Numerous battlefield stressors. You all know about improvised explosive devices. Other things don't get so much play. The sleep deprivation, combat, of course. For the medical staff, you'll hear about them working with the wounded soldiers, and certainly they have, but 90% of a hospital in theater, and when I say in theater, that's the theater of war, Iraq or in the past, Afghanistan, 90% of the patients will be either third-party nationals, locals, children, detainees, and those are the ones that you can't quickly fix and send back to the States, but instead you are with them for a long time, and then you are often discharging them to a medical system that is not able to take care of them, and that can be very difficult for the medical staff. The good things about this war is there's very strong support from the American people. One thing I miss about flying in uniform is when I was on active duty, everybody would come up to me and thank me and shake my hand. There's been a lot of new programs that have been developed, but despite all of the new programs that have been developed, there's a lot of problems. The other thing is that we've been an all-volunteer Army. Now, this again is somewhat controversial. Some people think that we should go back to the draft, and we can come back to that if we have time. It's an Army that's volunteer. They know they're going to war. It's no longer, hey, I joined for the GI benefits, and I didn't know that I was going. And since 9/11, people have been going over and over again. We've got very good data on the effects of combat on soldiers. The mental health advisory teams have been surveying soldiers in theater just about every year since 2003, and we know that we've had about 15 to 20% of soldiers who report symptoms of anxiety and depression. You've heard about the suicide rate going up and up and up. There's the wounded soldiers, ones that are very severely wounded that would never have survived other conflicts and are now surviving, but perhaps they're triple amputees or paraplegics. There's the effects on the families, and we tend to think in terms of the deployment cycle being over and back, but there's the families of the wounded who are now caretakers for their severely wounded children, you know, kids who had gotten out of the home, gone off to fight the war, and now dependent on mom again. And then there's we think of moms and children, but there's the brothers and the sisters of the wounded and, of course, of the deceased. A difficult economy is actually a very good thing for the military. It was tough to recruit back in 2004, 2005. Now the recruiting stations are inundated by people who want to join, and we can be more selective in who we take. So there's a range of deployment-related stress reactions. Congress and the American people tend to think of it in terms of post-traumatic stress disorder, and that's where the money goes. So we get $300 million here for PTSD and another $300 million for traumatic brain injury, but we all know that it's a range of reactions to include suicide and some of the risky behaviors such as driving too fast on the motorcycle. To remind you guys, and I know you know this is a diagnostic concept for PTSD, traumatic experience, the 3 types of symptoms which cause impairment in functioning, and a persistence of symptoms. There's 2 points that I'd like to make on this slide, and one will tie into the DSM-5 discussion this afternoon, and that's the so-called criteria A2, which is that this has to be experienced with fear, helplessness, and horror. And the thing for our soldiers, by and large, they haven't had fear, helplessness, and horror. They are trained that when the bomb goes off, when the IED explodes, when their Humvee flips up and goes over, they get out, they pick up their rifle, they lay down suppressing fire, they pull their wounded comrades into safety, they keep moving. They don't sit there and freeze. This is their training. But the issue has been, well, they still have the intrusive thoughts and the pictures of their dead buds or their severed limb in their heads. And so when they present for treatment, there's been a lot of discussion about whether or not they really have PTSD because they don't meet criterion A2. Should they be anxiety disorder not otherwise specified? Should they be adjustment disorder? And this plays into the disability and compensation question. So for a few years, if you have PTSD, you automatically get 50% disability. If you don't necessarily. The other thing I want to point out is that our soldiers, and I say soldiers, but I mean service members in general. It's just I was in the Army, so that's what I use. Our PTSD is not its own diagnosis. You hear about PTSD and TBI being the signature wounds of the war. I prefer the concept that the blast is a signature weapon of the war, and the blast will cause PTSD, traumatic brain injury, facial disfigurement, hearing loss, amputations. So our service members have multiple symptoms. The other thing is, if they just have PTSD, if they're not wounded, they try to hide it. PTSD is now sort of okay if you've been wounded, but if it's just PTSD, you're still sort of looked at as weak, and I will come back to that again. So the cases of PTSD have gone up steadily as the war went on, especially when the fighting was heaviest. This slide is diagnosed PTSD. We all know that there's a lot out there that don't go for treatment or for help. The question is, how much are the numbers? Is this 3% of the total? Is it 10%? We're not sure. But we are going to see emerging cases of PTSD over time based on every other war that we've had. Traumatic brain injury, a lot of discussion, and at first we under-recognized it, under-screened for it. Now some people think that we're over-screening, and we have cognitive tests before people go, and after they come back. They're called ANAMs, Automated Neuropsychological Assessment Metric. One of the issues, and this again is a subject for another talk probably, is that ANAM is not very specific and is very sensitive, can be influenced by sleep, fatigue, but at least TBI is being recognized a problem. Again, there's an overlap between TBI and PTSD, and it's often accompanied by pain and disability. And it's not just blasts that cause the pain and disability. A lot of our soldiers have simply musculoskeletal injuries because they've been in the military for a while. They've been jumping out of perfectly good airplanes. They've been hopping on and off of trucks. So you've got the knee strain and the back pain and all the other stuff in relatively young folks who may be 35 or 40, but have been wearing and tearing their body for a long time. And of course, the issue with traumatic brain injury is, like PTSD, we don't have good tests that can distinguish, especially mild TBI, which is really what I'm talking about here. If you have a bullet hole to your head, you know, everybody's going to recognize that. But if you simply banged your head a couple times, well, who here hasn't banged their head a couple times? I certainly have. So the third major area that I want to talk about is suicide. And again, you've probably seen some of this. You've seen the Time article by Mark Thompson on 1 suicide a day. This is the Army. This is the other services. The Army has been climbing and has gotten even higher since then. In the beginning of this, we didn't know whether this was simply normal variability. Our rates for many years were between 10 and 12 per 100,000 per year, but it's been going up and up and up. More recently, it's flattened a little bit in active duty, but still is high in National Guard and reserves. What are the risk factors for suicide in Army personnel? It's not what it is in the civilian world, although, of course, there's some overlap. I believe everything in life is a Venn diagram. So what you see in our service members is basically that they're humiliated. They get in trouble. They have a breakup. And you've got that gun in the nightstand right there. Or if you're in theater, every person has a weapon. So you've got some adjustment disorders. And by the way, we know more about our completed suicides than anybody else. We can tell you risk factors for every one of our suicides since 2001. And there's a paper I can send you with more details if you're interested. So it's a combination usually of relationship, legal and occupational problems. It's very often impulsive. About 16% do it on alcohol, which is a little lower than you'd expect, but certainly alcohol abuse is a factor. About 70% with firearms. In the theater of war, it's nearly always the member's military weapon. Back here, it's usually their personally owned weapon. Now, I think gun ownership has been a third rail until recently. We haven't been talking about it hardly at all. There's been various Department of the Army task forces, Department of Defense task forces that has tons of recommendations, and what I call responsible gun ownership isn't in there, or gun safety, and of course that's a political issue, and of course the National Rifle Association has been very far forward as to wanting to make sure that service members don't get their weapons taken away. We're beginning to engage on that as a dialogue. We talk about motorcycle safety. We talk about don't drink and drive. I think it's time to start talking about don't drink and play Russian roulette. Okay, so that's the background. And now how do we tie it in with the basic principles of medical ethics, which you all know so well that I don't need to remind you of, but they're a little bit different in the military context. One is, what autonomy does a soldier have? You remember the time around anthrax when the soldiers were told, you would take this anthrax vaccine, and if you don't, you'll be discharged from the Army. There's a question of justice, which in this context is mainly, I'm going to talk about who gets what kind of treatments, and of course beneficence and non-maleficence, doing no harm. For a military psychiatrist, and this is me when I was on active duty, my hair was shorter, I wanted to talk about the concept of double agency, and you all are familiar with that. We're serving the soldier, we're serving the Army. There's also, we're serving the U.S. and national security, and one of the things that folks run into at times is sometimes if you're in the military, you feel, well, it's the right thing for the country to talk about this as an issue, but then it rebounds poorly. And I'll give you the example of the forensic psychiatrist at Joint Base Lewis McChord at Madigan, who got quoted as saying, well, every case of PTSD that we diagnose costs the taxpayer $1.5 million over time. Now, he was pilloried and basically ruined for saying that, but you can also make the argument that you have to have responsible diagnosis because the taxpayers, not the Army, the taxpayers are going to be covering that money. Now, again, we can debate back and forth, and I know this is a very sophisticated crowd here about compensation, but there are several masters. And then the other dilemmas I'm going to focus on here is keeping the soldier on the battlefield, fitness for duty, confidentiality, and disability. If we have time, I'll talk a little bit more about detainee issues. So, this is what military psychiatrists have wrestled with since World War I and World War II, coming back to my first slide about the history of this. If you keep the soldier on the battlefield, you tend to do better for the soldier and better for the Army. But there's pros and cons. I've got good buds who are wrestling with this every day in Afghanistan, and what should you do? Actually, soldiers with PTSD usually don't present and say, I want to be evacuated home. Soldiers with PTSD actually function very well in the combat theater. They've got hypervigilance, well, that's great. They've got numbing, well, that helps you with things. It's an adaptation that's very useful for combat. It's when you come back home and you don't know how to talk to your wife anymore, or the irritability comes up a lot. And by the way, another piece on the diagnosis of PTSD, what we're seeing a lot is anger and irritability, and that isn't in the diagnosis, but it certainly gets into people's way. So I've split up these next couple slides into what are the pros of staying on the battlefield, and then what are the cons, or what are the pros to coming home. So if you stay on the battlefield, we have psychiatrists, we have combat stress control teams over there. You can be treated with PIs, you can be treated with medication, mainly SSRIs. We do CBT in theater. Cognitive behavioral treatment. The really good thing is that you're staying with your unit, you're not being sent back as a sleaze bag, dirt bag, sleaze ball, and there's a lot of other names that I won't use on videotape, but are there. And you're far more likely to stay in the Army. If you get sent home, you're less likely to stay. And then the Army Medical Department motto has been to retain the fighting strength. You don't have to be replaced. Now, on the other hand, in this day and age, again, as we're drawing down, we don't need as many troops in Afghanistan. We're not on the constant op-tempo, operations tempo that we had before. So if you come back, we can send somebody in. And people these days really want to deploy, especially if they haven't. They want to get what we call the right shoulder patch, which shows that you've been in battle, because that helps with promotion. Okay, so this is PTSD. Now, traumatic brain injury, similar dynamics as to whether you should stay or whether you should go. Reason for staying is it usually resolves after a few days. Very similar treatment, rest, good sleep, stay what we call in the wire, behind the wire. In other words, don't go out off the base. And if you stay, you're more likely to stay in the Army. On the other hand, we also know that even if you get it better after a few days, the more TBIs that you have, the more likely you are to develop problems over time and perhaps lead to dementia later on. And even though the soldier says, hey, doc, I want to stay here, I want to stay with my buds, are you doing better by the soldier and their family to send them back home? They're probably better treatment back home, although they do have pretty sophisticated cognitive rehab in Afghanistan now. And again, you're less likely to stay in the Army. You're more likely to be medically discharged than you might be psychiatrically discharged, but still it's a problem. And I'm going to cover this slide, and then I'm going to pause and see if there's any questions. I will ask people, if they ask a question, to stand up so everybody can hear them, name who they are, and keep their question pithy. And if there's no questions, we'll keep going on. I know for a bioethics audience, pithiness is a challenge. Oops, did I say that? So now another example where the dynamics are very different. If somebody is suicidal, then the impetus becomes to send them home. You all may remember the shooting at Camp Liberty 3 years ago. If they're suicidal or homicidal, the dynamics are pretty similar. Again, the pros to stay with unit, stay in Army, and one's always worried about an epidemic. If that person says I'm suicidal and I send them home, will everybody say I'm suicidal because they don't want to be here, they're tired of the heat, the dust, and so I really want to keep them there. On the other hand, it's really safer for everybody because you can't really secure weapons in theater. So if somebody's suicidal, they'll usually take the bolt out of their weapon because you have to go into the mess hall, you have to have a weapon with you, but it's pretty easy to grab somebody else's weapon. And that's what happened in the Camp Liberty shooting 3 years ago. To remind you, allegedly, if the case hasn't gone to trial, the sergeant there was seen at the clinic, said he was suicidal. He was put on suicide watch. He had a unit escort. They left the clinic, but then Sergeant R grabbed the weapon from the escort, came back in the back door, shot and killed psychiatrists, an Army psychiatrist, a Navy social worker, 2 patients, and an escort. And so it's really hard to keep weapons very secure. And if you're in the combat zone, you need to have weapons in order to do your job. Very rare that you can't. So, as I promised, let me pause there before I go to my next ethical dilemma and see if there's any comments. Seeing none, avoiding dead time, we will go on to the next ethical dilemma. This is something that we're really wrestling with now a lot. And now that I'm retired from the military, I can talk about things that I couldn't when I was on active duty, as Jonathan and I were talking about earlier. So the mantra from the Department of Defense is decrease stigma. Seeking help is a sign of strength. And they have people who get up there and say, well, you know, I saw the bombing in Mosul where 17 were killed in the mess hall and I had nightmares and I got help and I'm fine, so you can do it too. That is the mantra. The problem is that's not what happens in reality. In reality, as I relearned every time I go to an Army base, if somebody says I have post-traumatic stress disorder and gets seen by a psychiatrist, they are nearly all being discharged from the military. Now, they may be being discharged with a medical discharge called a medical board. They may get benefits, or an administrative separation where you don't get benefits, or they may simply, their time is ended, what we call ETS, and they get out. But by and large, if you are seen as having PTSD, you are seen as somehow being broken or weaker. Now, we've been working on this for 5 years. So back a couple slides. Oops, can you go back for me? A couple slides. I was back in 2007. I was doing a training. Keep going back on PTSD and post-traumatic stress disorder, and we thought. Keep going back. We thought we had fixed it by now. I can do it now. Never mind. Well, I keep going back. Keep going. Keep going. Keep going. Keep going. Keep going. Keep going. This is too far back. Forward one. Okay. No. All right, never mind. The point is that we've been training about PTSD and TBI for a long time, and people mainly feel that the senior Army leadership gets it, but what you see when you're there is that there's still a lot of discrimination. And so people do get discharged from the Army. So how are you going to handle this the different pieces of what to do about it? Not a good answer here. I was talking to an intern yesterday who works for a congressman who says, I want to decrease stigma, and we want to pass legislation to decrease stigma. Well, frankly, legislation doesn't decrease stigma. It's what you actually do. So if somebody seeks treatment and is taken care of in a nurturing manner and can persist in a military career, they'll get treatment. But soldiers are smart people, and if they see that so-and-so goes to get care and he is now being processed out of the military, they're not going to go anywhere near you. Now that flows into the next topic that I've got, which is confidentiality. Confidentiality is really tough in the military because you've got these two competing needs. You've got the privacy and personal health information of the soldier, and that is private and confidential, except when it impacts on fitness for duty. And then it becomes, how do you define for fitness for duty? So the commander, usually the company commander who's a captain, or the brigade commander who's a lieutenant colonel, needs to know how many of their troops they can take into the fight. They can't find out at the last minute that instead of taking 100 soldiers, they can only take 50 soldiers. They need to know. The other thing, back to the suicide, is commanders always say, well, I need to know about the health of Jonathan so that I can treat him right, so that I can make sure he gets treatment, so that if he's hitting his wife, you know, we can intervene. Well, the last thing Jonathan wants is for me to know that he's hitting his wife or having nightmares because he's worried about his NCOER, that's non-commissioned officer report, or about his report. And in this difficult economy, Jonathan's got 10 years in the military. He doesn't want to be discharged. He wants to make it to retirement and get 20. So you've got this uneasiness that comes out about what does command need to know. And by the way, after there's a suicide, it's always the finger pointing of, I didn't know that information. You may have read, there was a rather tragic case of a female soldier who shot herself in a guard tower a few weeks ago over in Afghanistan, and she had received treatment. And this is in the news, so I can share it with you. She'd received treatment for suicidal ideation when she was at Fort Knox. And so Afghanistan, her receiving command, didn't know that. And so they were, well, we should have known. But the problem is if you send somebody in and you say, oh, by the way, this soldier's been suicidal, they'll say, I don't want that soldier, you know, keep her back there. And this young lady apparently really wanted to deploy. So you've got this continuous tension between what command needs to know. There's some obvious things. So if I break a leg, it's obvious command needs to know that. What about if you've been hospitalized? Well, command needs to know that because you weren't at your duty station, and if you got into the hospital, you got there because somebody thought you were a danger to self or others. Now, psychiatric hospitalization usually leads to discharge from the Army, especially, and I have to emphasize this a lot, the Army is downsizing. We're not where we were 6 years ago when we were basically wanting every soldier we could get. We're going down in money and time, so commanders and the Army are looking at discriminators to get people out. Similar to substance abuse, command wants to know, so then they can refer you into a command-directed substance abuse treatment where there's essentially no privacy. It's a command program, and if you slip up and drink when you're supposed to be abstinent, you're out of the Army. And then there's these gray areas, and I just gave you an example of a real-life one. You know, this past history of suicidal ideation, periodically commanders want to have a suicide log, so when somebody goes from one post to another, from Fort Bliss to Fort Knox or to Fort Stewart, that the command knows in advance that they've had problems, again, so they can take care of them. But again, this impacts their career, and usually they leave. So, disability. This is really, really hard as it is in your world, but it's going to just be tremendously enormous. There's two, at least, major themes here. It used to be you got out of the Army and you got a disability rating, and then you got to the VA and you got another disability rating. Actually, they're now combined in the Integrated Disability Evaluation System, which is approximately a 2-year-long process. So you got that PTSD and maybe something else, and now you're in the Army facing getting out, but it's going to take you a year or 2 years to actually do it. In the past, about 7 years ago, PTSD wasn't adequately compensated. And it maybe got 5% in the context of you lost your leg, that's 50%, you get your eardrums blown out, that's another 20%, and here's 5% for PTSD. So the decision was made that all cases get a 50% disability. And that's a problem because there's no motivation to get better. And you all, again, are very familiar with the negative unintended consequences of having a disability rating. Several things. Soldiers don't want that anxiety disorder, not otherwise specified, or major depressive disorder or adjustment disorder, because you don't get that 50% that they want. This is very frustrating to the therapists who are trying their best to get the patient better. And in general, this is oversimplification, but in general, there's two types of soldiers in the military, in the Army. There's the ones that will never go near mental health because they want to stay and make it their career, and they want to go to school. And then there's the ones that are heading out the door, either for medical discharge or they've gotten in trouble, some kind of misconduct, and all the incentives are to develop all the possible disorders that you possibly can. And then the people who are on this side see the guys who are on that side, and their opinion of them, is further down because he's clearly a sleazebag for trying to get everything he can to milk the system. On the other side is that the soldiers who are getting out are told, you need to document every condition that you have so you'll get VA benefits. The other piece is that the psychiatrists, of which there are too few of in the military, and if any of you are interested in joining the military, let's talk afterwards because we desperately need you. See, I still say we when I'm in the Army, so it's sort of in the blood even though I'm not in uniform anymore. But so all this administrative processing is drawing the psychiatrist's time away from seeing kind of the fresh cases, and they're seeing those in the medical board system over and over. Now, finally, for the big topics, I want to talk about equal treatment for all. And one of the challenges that the military has is at the beginning of this war, they clearly didn't have enough of anything. And 11 years later, they're really overstressed and overstrained. So, for example, in the Army, there's about 100 psychiatrists on active duty. That's not very many. We've had 2.5 million people deployed to war. There's 120 psychologists, et cetera, et cetera. Congress has given the military a lot of money, and that's good. Except what it's led to is these shiny, very cool new treatment programs, such as the National Intrepid Center of Excellence, which is in Bethesda and is being set up at Camp Lejeune and Fort Campbell and a lot of other places, which are really the Cadillacs. They have intensive treatment. They have all sorts of stuff for both traumatic brain injury and PTSD. The challenge is only a very small fraction of soldiers can get into these programs. And so you'll have one person who has 3 weeks, 4 weeks of really intensive treatment, teams of therapists, everybody doing very well by them, complementary and alternative medicine, which is being done quite a bit in the military, yoga, Reiki, acupuncture, and then you'll have the kid that's seen every 3 months for half an hour by a specialist and whose PTSD is essentially goes from acute, where it's treatable, to chronic, which is a lot less hard to treat. And this is not an easy thing to know what to do with, and in part is, again, there's this big infusion of money which the military has to spend, but it sure makes me uneasy about what we're doing. There's also inequalities in terms of rank. This is traditional. If you're a general, it's easier to get the appointment the next day. If you're a private, it may be 3 months. We know about evidence-based treatments, prolonged exposure, cognitive processing, cognitive behavioral therapy, which are offered in some places but not others. A challenge is most of these treatments take 12 to 20 sessions. Soldiers are moving too fast to go to 12 to 20 sessions. The average mode of treatment is 3. They're going back and forth to the firing range, to Joint Training Readiness Center, to Afghanistan. So how can you get people get the treatments that they need? And then some of them are being referred off post to TRICARE providers. TRICARE is sort of our managed care system, who may or may not know anything. They may be very good in EMDR, eye movement desensitization, reprocessing, or they may know nothing about evidence-based therapies for PTSD. There is a lot of training going on for civilians, but that's one of the challenges there. How am I doing on time? I think I've got a couple more minutes. All right. Well, then I want to talk a little bit about detainee issues. So one of the challenges that we've had since the beginning of the war, and we should have known better, is how do we take care of people in our custody? And we, I mean the medical department. Every war produces prisoners, produces detainees. Yet every war we seem to come to it and say, well, oh, I didn't know we'd be responsible for 20,000 people at Abu Ghraib. And so we go in, and the medical issues that get talked about are the ones about abuse of prisoners, which actually isn't an ethical issue. That's clearly wrong. Torture is clearly wrong. But others are, how do you take care of 20,000 detainees at Abu Ghraib? Can you get rid of the little box there for me? When you don't have a CT scanner or an MRI or a psychiatrist and you're a physician's assistant. So it's a classic issue of not enough resources, but really, really not enough resources. And this is what has really hampered a lot of the medical personnel. And then, of course, everything gets so totally political that if you want to reach back and say, I don't have the tools to do my job, it becomes very hard to do so. Now, I think the military has made progress in this area. It's certainly better, the detainee care in Afghanistan, now than it was at Abu Ghraib some years ago. But again, there are enormous issues around taking care of detainees, who, by the way, are not grateful for your care, but are trying to stab you in the eye with a pencil or stab you with a shiv. The detainee camps are 300 or 400 people, so if you go in there as a medical personnel expecting kind of them to value you and honor you, maybe they will, but maybe you'll also be hurt by the detainees you're taking care of. This picture here is actually Dave Benedict and I in Abu Ghraib when we were going to look at the mental health needs of the prisoners. And that, by the way, is another thing that was underlooked at the beginning of the war. People weren't paying very much attention. Similarly to the jails here, where we have a lot of people with mental health needs, there was a lot of people in the Camp Bucca and Abu Ghraib who had major mental health needs, who were either the disruptive ones on the streets that were picked up by the police, or in some cases were the ones that were being recruited to be suicide bombers. So I think, again, it's something that I hope in future conflicts that we can know that we're responsible for medical care of detainees. I'd like to close with a couple of words which are soldiers really don't want to seek care in the traditional mental health model. They don't like going into that clinic, whether it's called mental health, behavioral health, psychological health, or substance abuse treatment. I've become increasingly interested in the complementary and alternative forms of therapy because the soldiers often will go for acupuncture, or my pet favorite is the use of service dogs and therapy dogs. This is some of the work we were doing at Walter Reed. There's a lot of very interesting programs where the soldiers are able to feel better because they're either working with that dog who understands them and isn't as judgmental as a therapist, or a couple of programs we have is the soldiers with PTSD are training dogs to be service dogs for other wounded service members, which brings into play all of the issues or all of the good strengths that soldiers have: altruism, wanting to take care of others, capitalizing on what they know. Unfortunately, the research is not out there yet in terms of most complementary and alternative medicines, and certainly is not there in terms of therapy dogs, but we're hoping, we published in a journal on this last April, and we're hoping to move the literature on, because again, many service members will not go to a shrink like me to get treatment. They'd rather kill themselves literally than go to a psychiatrist, but they will do other things that help them feel stronger and more empowered. And by the way, at least anecdotally, they seem to get better as well.
I'd love to hear your thoughts on the sort of infrastructure changes that might be needed in the VA to address the treatment of PTSD, where you're dealing with an additional or different set of problems. It's not just a concern about whether soldiers are prepared or vets are prepared to present, but whether you have the infrastructure to deal with them when they present. And then the two other issues that I'd be interested in. Okay, yeah, sure, go ahead.
I am not in the VA. Who here works at the VA? A few of you. But I've been around it for quite a bit. In brief, I think the VA is actually doing very well in many efforts, and I can't say what is secret, but this isn't secret. The VA has done a lot of work with secret in terms of the IOM committee report and all of that. The VA has done a lot of work in evidence-based therapies. They've got some really innovative programs. They're overwhelmed, they're swamped, and it's only going to get worse. And I don't know if anybody from the VA, after your other questions, wants to add to that, but let me take your next one.
Okay, and then just whether you have any thoughts. You spent much of the time talking about soldiers who had seen their buddies get blown up, and then you touched on detainees, and there's a couple of other populations I'd love to hear your thoughts on. One is those who might be suffering from what you might call moral injury or moral discomfort because they've witnessed or feel complicit in abuses or other behaviors. And the second is women who have been raped while serving in the theater of war, and their sort of PTSD concerns.
So the first one, PTSD and moral injury. Moral injury is a term that's been used by Jonathan Shea for a while. It's being picked up more, and it usually has to do with having done something like killed somebody, whether deliberately or inadvertently or in other ways, than something that was sanctioned, but that as a human leaves that scar in your soul. And there's an overlap with PTSD, certainly, but PTSD has more of the you've seen bad things, not necessarily you've been perpetrated bad things. And I think we don't really know enough yet about whether treatment is effective. Back to the narrative, I think it does help people to be able to talk. One of the challenges is if you talk about something that might be considered a war crime, if you tell me as your military psychiatrist, I have to report you. And often there's a gray area. Was this shooting a family, was it a war crime or not? People really struggle with the guilt related to that. In terms of sexual assault, all of the issues there about confidentiality and people not wanting to be labeled. You know, if I have PTSD from my sexual assault, it's sort of a double whammy. I've been raped once by a service member, and now I'm being discharged from the Army. Am I being, traumatized several times? So absolutely, that's a very important issue. And unfortunately, the DoD, although it's been trying for years to decrease rapes, the numbers are just going up. Okay, I wanted to give time to the audience. Raise your hand if you've got a question, and we'll go 1, 2, 3 or something like that.
This gentleman here.
My name is Mark Allen. I just wanted to know what is the normal response? What would be considered a normal response? Being in the theater of war and you see your buddy blown up and you're shooting other people and knocking them off, without being your own, well, maybe friendly fire or whatever. But if you're in that situation and you have all these terrible things that are happening, what's the normal response to that? I mean, what should the normal
Right.
person be responding to?
Well, obviously, Mark, that's a trick question. Because the normal response is hypervigilance. The normal response that I had when I was over there is actually your emotions get really flat because you can't be all over the place. So you sit and smoke a cigarette before you're out on the convoy, you joke, you're kind of fatalistic, and so that is normal. And the blurring between what some people call post-traumatic stress and post-traumatic stress disorder is really when the symptoms get in your way back here. A lot of people are going towards the term post-traumatic stress injury. You all may have heard that because they think that it's more appropriate to consider it an injury of war rather than a disorder that something's wrong with you. So it's a spectrum, obviously. I know that I myself, certainly I can't sit with my back to the door. That's normal. When I came back from Somalia, I hit the floor when the firecrackers went off. That's normal. Did it go into disorder, which helped me function the rest of the Army? Yeah, I'm still here. I'm doing okay. We had a... Very good question. You all have probably heard about Comprehensive Soldier Fitness, which is a resiliency program. And in general there's something called have you all ever heard of a GOBI? So those of you who have been in the military? Well, GOBI is a general officer bright idea.
Yeah.
And that's when the general says, we're going to prevent suicide or we're going to prevent PTSD by putting some program into place. And the current program is a resiliency building program called Comprehensive Soldier Fitness. The challenge is it's easy to talk about developing resiliency. It's very hard to know how to actually do it. Basic training, which is 9 to 13 weeks, depending where you are, is a resiliency training. It's where you get physically fit and you learn how to use a bayonet and you learn how to crawl under barbed wire. Is another hour or two of about a PowerPoint slide really going to help? We don't know the answer to that. Another GOBI is always that we can just screen. We'll screen out the people who shouldn't be on active duty. And again, when you go back to the history, and we've tried to do that, our screens have insufficient sensitivity and specificity. So we either screen out too many people and we can't let them in, or we let people in and they develop problems. It's something that the military is all wrestling with. As I mentioned, now with a difficult economy, people are screening much more closely, fewer people are getting in. Will that decrease PTSD, or are the horrors of war too much for anybody? There's probably a balance there between what somebody brings in with them. We do know there's a direct relationship between the number of firefights that you've been in and the chances of developing PTSD.
This gentleman here.
Do you believe that soldiers with PTSD and other mild traumatic brain injury, do you think they should be eligible for awards like Purple Heart if we're considering PTSD and injury in the same way that physical injury is considered?
You guys have good questions. So the question about the Purple Heart has been debated very hotly. The criteria for it are you were supposed to have received an injury directly in combat by enemy fire. For traumatic brain injury, and it can't just be hitting your head, so this would, if a bullet hits your skull or your helmet and rattles your skull, you actually are eligible for a Purple Heart. PTSD has been more contentious because it's harder to say combat direct injury, and so far it hasn't gone there. The Canadians, and we've got some Canadians here still, the Canadians I think handled this they gave an award specifically for PTSD, what's it called, Survivors Award or something like that, but it hasn't been, it's been kind of stigmatized itself and sort of made fun of. So I cannot give you a clear recommendation on that. There's pros and cons of each.
Paul Ford, and you raised the number of rented issues. I was very excited and pleased with. I didn't expect the detainee issues. I wonder if you could extend that further to the bystanders that folks may observe as medical professionals in the communities around the bases in the theater. Those villagers who may have in the village or others, whether they're that post-traumatic for them, in seeing the conflict might be different. If there's any sense of obligation or tension in the psychiatry world while you're in the theater to try to help some of those.
As I think I understand the question, there may be two in there. One is, what about PTSD in the local traumatized population? And then the second is, do you have a responsibility to try to treat it? Unquestionably, there's post-traumatic stress disorder in Iraq. I actually went over there in 2004 to try to help the Iraqi physicians deal with it. They've had 35 years, Saddam Hussein, people executed, etc. It's endemic. The next question, do you try to treat it? I think it becomes very challenging to treat PTSD in a different society. It's easy to treat psychosis. We were talking a little bit about this last night. You can give medications, and we did when working with the detainees that help with the psychosis. But the cultural issues around treating post-traumatic stress disorder, I think, fools rush in where angels fear to tread. So I think it's got to be done carefully, culturally competent, and the direction we were trying to go was actually to assist the Iraqi psychiatrists and others with doing it rather than trying to do it directly.
Julie Altman, you mentioned moral kind of injury for the soldiers. And in healthcare, we talk about moral distress among the healthcare providers.
Can you speak up a little bit, make sure everybody can hear you? Thanks.
You mentioned a moral injury with the soldiers, and we in the healthcare profession called moral distress among healthcare providers. And I was wondering if you could speak to being a healthcare professional, working with healthcare professionals that are finding themselves that moral anxiety, that moral distress that they're facing.
Yeah, or by other terms, you can call it compassion fatigue or provider fatigue, or just listening to story after story of what people went through. It certainly wears on the providers. There's no question about that. We actually did a survey of providers, and especially people who were in the behavioral health field. You know, it's in some ways easier for the surgeons because they can get in and do their stuff, and they don't have the repeated secondary victimization or whatever you call it. So it's easy to say it's a problem. The challenge is what to do about it. And the models that we, at least in the Army, developed to try to treat provider fatigue tended to be a sort of stress management model. You needed to eat right, sleep right, don't smoke too much, don't drink too much. Well, we all know that already. And then I think where it needs to go next, and we've had some discussion about this, is two ways. One is if people feel recognized and validated for what they've done. So if a young psychiatrist who's burned out can come to the American Psychiatric Association and give a talk about it, that helps. And then the other thing tends to be an almost existentialist talking to what does this all mean. And frankly, I don't think we've processed it yet. I don't think we as a nation have processed 9/11. I know my colleagues have not processed 11 years of war. We haven't processed the Fort Hood shooting, where one of our own went and perpetrated the violence, or the Camp Liberty shooting that same year where a psychiatrist was killed. So, you know, it's a good question, and I don't have a clean, easy answer. It's going to take us a while. But I do think talking about it helps.
Somebody from this side of the room? We haven't had someone from this side of the room for a while? Yes, Susan.
Susanna Rose with the Plenary. One thing I was thinking about is you were talking about alternative therapies as sort of a different or less biased or kind of less...
More accessible.
Yeah. I was also curious about the role of chaplaincy or spiritual support because I know the medical community and in hospitals sometimes, I'm not a psychotherapist myself, a lot of times people wouldn't see me, would be very happy and wouldn't feel that stigma with a very well-trained chaplain. So I was wondering how that might be used.
Sure.
And not even necessarily to assess or the spiritual issues, but to use different personnel who don't have that stigma, but
Right.
really to do the same kind of thing.
Well, the military makes a lot of use of chaplains. So every battalion has their chaplain. And they do a lot of things similar to combat stress control teams where they're getting out of their office and they're doing therapy by walking around and are out there. And we really rely on them. Especially, I mentioned that if somebody tells me about a war crime, I have a duty to report it. A chaplain in general does not. So they can be incredibly valuable asset. I will say, though, that many soldiers don't want to go to chaplains either because they're worried that the chaplain's going to then refer them to combat stress control or to a psychiatrist, and then people have their own belief system. But certainly chaplains are invaluable, but we kind of need more than chaplains. We need to have every portal be open. And again, this is what I'm struggling with. We want people to get help, but I don't want to end their career if they get help. So some of my colleagues are all for, let's do more screening for PTSD. Let's make sure we identify them. But if once they're identified, that becomes a slope out the door, then that's not the right thing either. So, you know, frankly, one of the things they can do either with chaplains or dogs or service dogs or whatever else is get the help and not call it that. Now, that's its own ethical dilemma. Are you underdiagnosing? Should you be making sure, you know, you've got to do an accurate diagnosis. That's part of your training. Gray areas here. I think there's a couple over here.
Marcus Brother from the UK. Are there any regular debriefing sessions that happen routinely, once a week or something, you know, for everybody? And would there be any evidence for the effectiveness of that sort of debriefing, where people put their experiences into some kind of narrative, so theoretically it could be effective? Does this think it?
Yes, the debriefing question, another hour-long talk. The concept of critical incident debriefing or after-action debriefing, which are two slightly different things. There's certainly in the military, there's a lot of informal discussion. We've gone away from the critical incident stress debriefing in general because at times it seemed to be making the problem worse. CISD is a 3-hour debrief. There is after-action debriefing. In the UK, there's the traditional deep lager therapy. You guys all know what deep lager therapy is? A beer at the pub, deep lager therapy. And Simon Wesley and Neil Greenberg and I used to talk about this, kind of a natural, let's get together with the boys or girls and let's talk about what happened. Now, I cannot, advocate drinking alcohol as a treatment for PTSD. But there's something to the bonding and solidarity that I think has really helped. And one thing we know is that in the United Kingdom, the PTSD rates are lower than ours for a variety of reasons. They're lower on active duty. They're a little higher on Guard and Reserve, who don't have the same ability to bond and talk.
We're getting close to time, so Paul, can we take one more? Or? Okay.
We had 2 more hands. Can we give 2 if they're real quick? I have 2 minutes.
Okay. Over here.
You mentioned concern for the mental health of detainees. How do you reconcile that then with the fact that places like Guantanamo Bay seem to have been deliberately set up to inflict physical and psychological trauma on the detainees?
I can't reconcile it. What happened was wrong.
Were there medical professionals involved with that?
Were there medical professionals involved in torture of detainees? There have been some allegations of that, so I won't say that it didn't happen. I'd say for the vast majority of my colleagues, they would have absolutely nothing to do with that. Final comment? No, he's good? Oh, the gentleman in the back has had his hand raised a bunch.
I work primarily with children and adolescents, and I've had an ongoing...
And your name is? We had a perfect run.
Ongoing issues nearly several years ago when the military was building regarding enlistment and prior psychiatric treatment. Are you aware of any discussion of that? Because many of the kids I saw, the reason why they were seeing me was totally unrelated to anything that might impact the military. But both the families, young adults, myself, and their enlistment officers struggled with issues of confidentiality, whether they were appropriate for military service.
So the question about pre-existing conditions, whether it be asthma or ADHD, is one that has always been a theme. And usually in brief, if you really need troops, you what we call waive the pre-existing conditions because you need to bring in as many as possible. And if you don't need troops like you've got now, you don't waive anything. You say if you have any history of counseling or ADHD or asthma, you don't come in. And there's standards and then there's waivers. So if you look through history, again, there's this back and forth. And what the recruiters always, what the drill sergeants always say is the recruiters told the kid to lie. And what the recruiters always said is the kid didn't tell me the truth. And then you also have this double bind that if the person tells the truth, they'll probably be excluded, especially now from military service. So just to summarize, it's this back and forth over time. The military would always like to see pre-existing medical records, but if you've got something in your medical record, like you've had a suicide attempt, you won't be allowed in the service.